presentation is COVID-19 vaccines and antiphospholipid antibodies, antiphospholipid syndrome. These are my conflict of interest. This is the title of a paper we recently published in Rheumatology that is impressive, really. The impact of COVID-19 and COVID-19 vaccination in high-risk patients with antiphospholipid syndrome, a nationwide survey in Italy. The background of this study was first that we were called by every part of Italy with people asking for, should I be vaccinated with the antiphospholipid syndrome or not? So we moved and say, we have to study this problem, otherwise we cannot answer by sure to this question. And also because patients with antiphospholipid syndrome and triple positivity for antiphospholipid antibodies, as you know, are at high risk of recurrent events of venous or arterial, in the venous or arterial circulation. Secondary prevention with warfarin is mandatory, while direct or anticoagulant are not recommended. Thromboembolic events may occur despite anticoagulation. In severe COVID-19, there is a strong evidence supporting a major pathogenetic effect of this disease in the sense that there is a procoagulant state associated with mortality, and autopsy studies have extensively reported the presence of macro and microembolism, the so-called immunothrombosis. About the vaccination, concern developed regarding the occurrence of a feared complication also in during vaccination, the days after vaccination. The vaccine-induced immunothrombotic thrombocytopenia, VIT, mainly related to the use of one of the vaccine, the Oxford AstraZeneca vaccine. So on this basis, you understand that COVID and COVID-19 vaccination was related to, in many aspects, to thromboembolic events. So as the COVID-19 and COVID-19 vaccination may induce thrombotic complication, the objective of our study was to assess the course of COVID-19 and adverse events after vaccination in high-risk APS population, namely triple positive patient, a population with acquired thrombophilia at high risk of thromboembolic events. Methods. And this was a nationwide multi-center survey conducted in 9 APS referral centers by means of a questionnaire. Included patients were thrombotic APS with the triple positivity confirmed 12 weeks apart. The reference specialist physician used a 4-graded scale for severity for COVID-19 and a 6-graded scale for adverse reaction to vaccination. Outcomes were considered within a 30 days period. The clinical evolution of previous SARS-CoV-2 infection was using a 4-graded scale of severity was as follows. 0 was considered patient asymptomatic, 1 mild symptoms treated at home, 2 hospitalization in non-intensive ward, and 3 hospitalization in intensive care unit. On the other hand, the severity of vaccination adverse reaction was graded according to the following criteria. 0, no adverse reaction apart from transient local injection site sign symptoms. 1, flu-like sign symptoms less than 1 day duration, and 2, flu-like sign symptoms or more than 1 day duration, and 3, symptoms requiring medical intervention, 4, hospitalization, and 5, potentially life-threatening reaction requiring assessment in the emergency department. These are the patients we collected, 161 patients. The mean age was 47 years. Most were female, and the majority were Caucasian race. The type of thromboembolic events were venous in 50% of cases, arterial in 30% of cases, both venous and arterial in 19% of patients, and 2 patients had a previous catastrophic antiphospholipid syndrome. The secondary antiphospholipid syndrome was present in 60 patients, and in most cases was the associated autoimmune disease was systemic lupus erythematosus. This is the flow diagram of the study. So we have 161 thrombotic high-risk triple positive patients. 18 patients had, at the time of interview, had the COVID-19 and 17 before being vaccinated, and 1 patient after had a DVT, deep vein, no, sorry, yes, 1 patient after 3 months after the second dose vaccination. 146 patients received the first dose of the vaccine. 129 received the second dose. 15 patients were unvaccinated, 13 because they refused vaccination, and 2 because they were waiting for a booster dose after having had the COVID-19. Of 161 patients, 18, as I said, had the infection, and 0 died. 0 were hospitalized in intensive care units. 3 were admitted to the hospital with flu symptom without pneumonia. 12 were treated at home by general practitioner, and 3 were asymptomatic. As far as vaccination is concerned, 161 patients, including the survey, 146 received the first dose of vaccine. In most cases was Pfizer-BioNTech vaccine, 122. In 20 cases was the Moderna vaccine, and in 5 cases was AstraZeneca, Oxford AstraZeneca vaccine that was at a certain point was not more used in Italy. 15 of these patients were unvaccinated, 2 of whom were waiting for the first dose after the COVID-19, and 13 refused the vaccination, and 10 of these patients who refused the vaccination refused because of fear and the vaccine disbelief. 1 patient with associated SLE followed the treating physician recommendation. In other words, the doctor following this patient said that this patient should not be vaccinated. 1 refused vaccination because of high titer positivity for IgM anti-SARS-CoV-2 antibodies, and 1 because of onset of serious illness. So let's take a look to the adverse reaction to vaccine first dose. The reaction to vaccine first dose were no reaction in most cases, as you can see for the green column. And there were flu-like vaccine less than 1 day or more than 1 day in very few patients. The medical intervention in very few patients, and no hospitalization as a complicating this vaccination. This was the first dose. Was the second dose, same thing, no reaction in most cases, flu-like and less than 1 day or more than 1 day in a few patients. Medical intervention, that means that the patient called the general practitioner for help in few cases, and no hospitalization again. So the conclusion from this survey is that physicians and patients with APS are concerned on the impact of COVID-19 and COVID-19 vaccination. High-risk thrombotic APS patient did not develop thromboembolic event, and the vaccination was well tolerated. These data are useful because these data reassure APS patients and caregivers and contribute in reducing hesitancy in unvaccinated patients. I thank you for your attention, and I am open to discussion.